Hello, I'm Dan Hawkins, and today we begin our next in the series of interviews of health center leaders as part of our Health Center History Project. Today we have John Silva, who is the head of
Greater Lawrence Family Health Center.
GLFHC
That's right.
in Hull, Massachusetts. Is it still mostly grounded in Hull? Is that its main?
No, that's up north. I started in Hull.
Uh-huh.
Hull's part of the Manic Community Health Center system now. We're about 30 miles north of Boston, up in near New Hampshire.
Wow.
So I've moved a long way over 40 years, about 50 miles in total.
Well, let's not count Oklahoma,
Right.
St.
New York.
Louis, New York,
Yeah.
all the places you've been. Let's start there at the beginning. What was it in your early life that you think led you to have interest in a career at a community health center?
Well, I was raised in a family where my dad was first generation Portuguese. His parents, my grandparents, came from directly from Portugal, and it was a hardworking family, hardworking work ethic, a lot of caring about people, about issues. It was also, I grew up during the Kennedy era and the Great Society, and
Ask not what your country can do for you.
and
et
the late
cetera.
'60s and Vietnam and all of those things. And so there was no one thing, but it's kind of the way I was raised. And my community, little town of Hull, Massachusetts, a peninsula and juts out in the Atlantic Ocean, had no health care, no primary health care, no docs.
It was a very seasonal
Yes.
area, right? Summertime, it was
Huge.
huge and bustling, and wintertime,
Dead. About 10,000 year-round folks. The high school, I went to Hull High School, and the high school was on the very point of the peninsula, the farthest you could go before you hit the water, which is a beautiful sight, and it still is. People look at it and think, I can't believe you went to school here. But in terms of access to medical assistance, you not only had to get to Hull, but you had to drive all the way through Hull. And what happened back when I was in school was a high school student had a seizure and died at the high school before any medical assistance. It was the time before ambulances and EMTs and fire departments doing all of that. And it caused a whole bunch of folks in town to start trying to figure out how we're going to get year-round health care. I was going to school then I went to college, kind of lost touch. There was a free clinic that ended up being located in the basement of my dad's dental office for about 4 years. I graduated from the grade school of Holy Cross instead of Boston College, and
lowly BC.
when I came back, I went to work at the State House. The community asked me if I'd help write a grant for this thing called a community health center. It was back when it was not HRSA, but
HSA,
yeah, HSA and BPHC and all that kind of stuff. But anyway,
BCHS, as I remember.
That's right.
Bureau of Community Health Services.
so I helped write this grant for this thing called a community health center. And lo and behold, it was funded in one of the new starts that was funded in '89. And I joke.
89?
79.
Yeah,
Sorry,
that's
79.
what I thought. We lose track of time.
Well, yeah, I am losing track of a lot of things. But in '79, and we got funded, and they hired me as the first executive director. As I've told you, we had 6 employees. I was a 22-year-old executive director. I'd never managed myself. 2 National Health Service Corps docs, 2 nurses, and a bookkeeper. I didn't know what I was doing, but I fell in love with the model. The model was so interesting because the board I reported to, most of them were patients of the health center, but many of them were people I grew up with or parents of people I grew up with. So that's how I got started. I originally decided I was going to be the governor of Massachusetts, and then I got kind of stumbled on this incredible movement, and it's now been about 41 years.
Wow. And you stayed at the health center as the CEO for how long?
3 years.
Okay, and then
Then I took
others
over.
noticed your.
Yep, I took over. I went to work for Jim Hunt at the Mass League of Community Health Centers. I ran at what at that time was a subsidiary of the Mass League called the New England Community Health Center Association.
So that covered the entire 6-state New England
Right.
region, right?
And I was there for a good 7 years. And at that time, the spinoff, Nietzsche became its own corporation. It spun off from the Mass League. But my first association president was Cornell Scott. Janet Stern was on the board, Ann Peters, David Reynolds, Jack Craddock. I mean, what a great place for a kid to get exposed to that talent.
And these were the folks who essentially recruited you to take that job at Nietzsche.
Yeah, yeah.
Wow.
And
And mentored you?
mentored me to a level I'll never forget any of them, because at the same time they were emerging as you were and as Tom was as the national spokespeople for this movement called community health centers. So I really learned, and including Jim Hunt, I learned from arguably among the best and the mothers and fathers of this movement.
But you didn't stay with Nietzsche. You stayed with them for 7 years.
Right.
But then you decided you wanted to get back into the health center
Yes.
round.
Yes. At that time, I got you would recall this. I was elected by NAC as the Speaker of the House. That made me the legislative
I do remember
committee
that.
chair, and you were stuck with me for a good 6 years. But I started to meet more of our colleagues, more health center directors from all over the country, and I got the bug again. I first looked at Boston and New England, because that's where my wife and I are from, but we were all young then. I mean, all the leadership was young. There was not going to be a lot of movement. There weren't a lot of openings. And then I got recruited by some health centers, and we ended up in St. Louis. And I went at Family Care Center in St. Louis, South St. Louis, and I was there, I guess my shelf life was about 7 years. We did some wonderful things in St. Louis, and it was a wonderful experience, but boy, living away from my safety net, which is all those people who kind of told me when I was doing things wrong or helping me to solve problems, I was on my own.
But the whole healthcare system was changing at that point.
Right.
With the advent of managed care.
Right.
And other organized delivery systems, et cetera. How did you confront that when you were in St. Louis?
Medicaid managed care had hit St. Louis, it had hit Missouri. There was all of these health systems and academic medical centers forming their own HMOs. And of course, health centers were a footnote to all that. Nobody really thought that we were very important, but as you know, I mean, the 4 big health centers in St. Louis controlled an awful lot, served an awful lot of that
Sure.
Medicaid population. Myrtle Davis, Betty Kerr, we were all together at the same time, and you helped us with this too, as you recall. We decided, to heck with this, we're not going to just become part of somebody else's HMO. Why can't there be a health center-led Medicaid managed care HMO? You flew out. Do you remember that?
Vaguely.
You flew out and met with all of us and a group of people, and because of an awful lot of what you taught us and the fierce passion and determination we had to kind of control our own future and make sure that the quality of care for our communities was preserved, we kind of talked St. Louis University School of Public Health out of an HMO license that they had but weren't using. I think they sold it to us for $50, and they had a vote, this epic vote, where 8 of us sat in a room, and the 4 who are the board of directors of the HMO on paper only voted themselves off, but first they elected the 4 health center CEOs on, and voila, we had a HMO license. Then we went to St. Louis Regional Hospital, which was the community hospital, and we convinced them, because no other hospital really wanted to play with us. We convinced them and the St. Louis Department of Public Health to partner with us. And to end a long story, we were awarded one of those contracts. We ended up with 22,000 covered lives, and the HMO itself was sold maybe 18 years ago. So it made it to the 2000s from 1991. I think it was about 2010 where it was sold to a larger HMO in the state of Missouri. But we proved, I don't know how we did it, but we proved that we could do it, and we could do it effectively.
Could operate financially secure, et cetera.
Yeah, and it was only places like, I think us, New York City. There were a few outposts of folks taking the shot, but we literally proved to ourselves, but we also proved to funders and to the larger environment that we were legit, that we could do maybe more than just provide terrible health care to poor people.
Yeah, like as the old SOP was.
That was the saying, second-class health care.
Health centers have never been second class, have they?
We were the first health center in the Midwest to be certified by the Joint Commission back before the Joint Commission had a health center segment. So they treated us, and there were a few other health centers in the country, like we were hospitals. They didn't know what to do with us, but we got the gold seal. That shook a lot of people up in St. Louis, that how could a health center be a Joint Commission accredited healthcare organization? There was this feeling that healthcare was second class simply because it was community managed through a board of directors. How could the community be able to manage this, something so complex? And our doctors obviously weren't of high enough quality. That's why they chose to practice in these poor and rural locations. The opposite was true. As you know, over the years, the results, the improvement of health disparities, the improvement of health outcomes has been amazing. And it's funny, one of the things that's always struck me is when we started, the medical societies, the hospital associations, mainstream medicine thought we were socialist, we were communist, we were just
Drinking
ridiculous,
the Kool-Aid,
right? And now, all these years later, who are our biggest partners? Who do we collaborate the most with?
Who comes to us?
Right.
Wanting to collaborate.
Right. So it's been pretty exciting. It may have cost me my hair and about 50 pounds, but it's been pretty exciting.
Yeah. It has been quite a life, hasn't it?
It really has been.
You know, the irony, the parallels between your experience in adult life and mine are so similar.
Right.
When I got down to South Texas, I had no idea what I was
Right.
doing. And when they recruited me to run the health center, I had never managed anybody, and I couldn't manage myself.
That was me.
That's exactly where we were. And it was learning by doing and finding other partners in the other health centers and finding mentors who would teach us the
Right.
ropes of how to do it.
The other good thing about it, Dan, too, is that there was nobody there to tell us we were doing it wrong when we were both learning.
Yeah.
This was all brand new. Nobody knew if we were doing it well or not doing it well because there was no litmus test.
Yeah.
And that, during my time, NAC became from a grassroots small association into a nationally recognized association. And it's amazing. It's kind of as NAC went, the health centers went, or as the health centers went, NAC went. The better we did, the more NAC could do. The more NAC could do, the better we did.
For all of us.
And it's just been amazing. The thing that I'm most proud of is all of the work that so many of our friends put into the National Association to make it the preeminent, as far as I'm concerned, healthcare association in the United States. What we've done, again, the little engine that could. You couldn't do your own HMO. You couldn't do couldn't provide quality care, you couldn't do impact health disparities, you couldn't become a national force, and we're now the foundation for primary care in the United States.
Couldn't be on the president's Council for Healthcare Reform.
Yeah.
That was an experience, wasn't it, for you?
Yeah, I lucked out. I'd just been elected president of NAC or president-elect of NAC, right around the Clinton administration coming in.
93, 94, yeah.
And Hillary had this idea of putting this together, and just because, I mean, I'm still pretty clueless, but because I was the president of the National Association, I got to play with the National Healthcare Task Force, the pods. I used to fly into the executive office building 3 or 4 times every 4 months. I felt like history was being made, and the coolest thing was that health centers had a seat. I mean, you and Tom were doing all the background work, but to be able to sit in a room with some of the organizations and the players that were there, we wouldn't have dreamt that
The AHA, the
15
AMA,
years ago. All the biggies.
all the big guys.
And for me, it was really exciting. I learned a lot during it that what is developed as good policy has to go through special interest groups, has to go through the media, has to go through so many different tests and adjustments and negotiations and changes to get the votes that I think you'd agree what the final product of healthcare reform was not what came out of all of those committees and all of that work. It was adjusted and changed and negotiated out, and it just wasn't what we finished with. But the process was incredibly exciting.
You know, my take on that, by the way, is that Obamacare was not only preceded by, but the pathfinders that led the way to Obamacare were those who struggled and didn't succeed completely, but set the stage with Clinton care,
Yes.
Hillary care,
Yes.
as they derisively called it. But that set the stage for the later iteration, which really, it took that long, you know, almost 20 years more before the country was ready for health reform. I think, quite frankly, that when Obama was elected, I don't think health reform was at the very top of his,
I don't think so either.
priority list. And yet, there were enough Democrats in particular, and health policy experts.
And visionaries.
Who felt that that was what needed to happen. And we were pleased and thrilled to be part of that process as well.
Well, and NAC was a huge part of that process, a huge part of putting that Obamacare together. And that also was how many years between Clinton and Obama? It's a short period of time, relatively speaking. And NAC and health centers went from having a role, albeit a smaller role with the Clinton activity, and behind the scenes having a very large role in the development of Obamacare, especially around primary care and access.
Oh, absolutely.
And that's in the span of health center started in 1970, 71, 69. Geiger
65,
Gibson,
but yeah.
65. Hey, I was just 10 years old then. But if you think about 65 to 2000, and let's say 2020, that's what, 60 years, 55 years? About right.
Yeah.
What we are and what we were the vision of community residents who were sick and tired of being ignored and treated like second-class citizens. And were too dumb, and I say that with all the love in the world because that was me and you, too dumb to realize that what we were trying to do you couldn't do.
Right.
And now you step back and you take a look at serving 28 million, almost 30 million Americans through thousands of sites and being the cutting edge providers of primary care, community-based primary care that's led by the patients. One of the reasons we survived the Reagan year when he defunded all of us one day. I mean, I'll still never forget that. And yet the outcry from across the entire country for how many days, maybe a week, had the administration back down, and suddenly we're back in the ballgame. That's been the strength of that consumer patient partnership has been really the key.
Oh, I think for all of us.
Yeah.
Being grounded in the communities we serve has been the greatest strength. And it is what has, carried us forward, boded us well, saved our butts
Yes.
from
Yes.
extinction
Yes.
on more than one or two or three occasions. It has made us into, we're not invincible,
No.
but it has made us so much stronger than we otherwise would be. Because these communities, I am convinced, and we've shown it over the years, will fight like hell
Right.
to keep their health system alive.
So the
It's
health
like-
center that I'm in now, I'm finishing my career in now. It's always strange when I say that, but
Full circle, huh?
the Greater Lawrence Family Health Center started in '79. It was all those new starts, remember, in '79?
Sure.
Started in '79 and started by community activists in the city of Lawrence, and almost went belly up halfway through the '80s. Pulled through that, and now Greater Lawrence Family Health Center is the 10th largest employer in Lawrence. We have a $70 million budget. We have 700 employees. We have 140 docs. We have one of the biggest family medicine residency programs in the country, and the only one that's owned by a federally qualified health center. We've got a giant pharmacy system, homeless outreach, Ryan White services. It's a major economic force, but it's also turned Lawrence from a desert in terms of access to docs. We're no longer an MUA. We're no longer a HIPSA. We're no longer, because of us. If we closed tomorrow, even the residency, it would go back. But I often think some of those people in 78, 79, 80 that fought just to do this,
Yeah. They never envisioned
They
something
wouldn't-
that big.
believe it. The
Yeah.
legacy is amazing.
Be like Rip Van Winkle. They came back, they wouldn't recognize it
Right.
at all.
Right, and but it's a credit to, there's been a lot of good people since, and working really hard, but it's those people. Every story is different in every community, but it's all the same. So anyway, it's been a great ride.
It has been a great ride. I want to talk to you about the residency program, but first, talk to me about quality of care. I know when you were out in Oklahoma, in Tulsa, you were very much engaged in focusing on the quality of care that Morton Health Center provided.
The key to credibility for our organizations, even today, because of the communities they're located in, services they provide, is that we've got to be able to show that our care is not as good as, but it's better than you can get in suburbia, at a group practice in a more affluent community. And so the focus in terms of quality of care, it begins with how the patients access the services, all the way through the referral process, the follow-up process. It focuses on the specific healthcare disparities, interventions, community outreach, education. The model, there was nothing in the book that said that was the model, but the model that's evolved is the whole enchilada. It's behavioral health is collaborating with mental health, which is collaborating with dental services, which is out in the community, where our doors are open. We have quality docs, thanks to the National Service Corps. Quality of care has become the, what do you call it? Quality care has become the adjective to describe health centers, where years ago the adjective was community-based.
Yeah.
Community-based is still there, but nobody can beat us in quality care.
No, it's
the
the
health
descriptor,
disparities
right?
in northern Tulsa dropped 4 to 5%. Things like if you were an African American male and you lived in North Tulsa, your death rate, what's the right saying? Your lifespan
Yeah,
was
life expectancy.
life expectancy was, if you can believe this, 15 to 20 years less than if you were a white male in South Tulsa, not a white male in New York City. Across the city, you could go from one place where males were dying 15 to 20 years earlier than white males, or infant mortality. Infant mortality rates were horrible. And it's not just what we did in Tulsa, it's what we've done across the country that you can reach out and touch. The infant mortality rates have dropped in those communities. Longevity has improved in those communities. Diabetes is a killer, and we all focus constantly on beating that. Colon cancer, it's just, every time I talk about it, did we really help do this? Did we?
The answer is we really did.
All these people that we know and that you're going to be interviewing, we're all part of this.
And now, in order to keep it going, we've got to focus on the future. So talk about go back to 1979, 80, 81 with your NICHA recruitment, clinician recruitment initiative, and take it forward to your residency training program.
That's
Greater
really,
Lords.
that's really brings back memories. It seems so basic now, but back in 79, 80, 81, 82, recruitment by health centers of physicians was a war. It was a constant battle. I wanted that doc. You shouldn't have that doc. You shouldn't have that doc. We might be all in the same state or the same region, but it was an individual recruitment process. And we had this idea that, wait a minute, why don't we promote New England, number one? New England is
Great place to practice.
No matter where you want to be, you can be skiing, you can be fishing, you could be hiking, you could be on the beach, you could be, it's a wonderful, wonderful destination. And some of us had this idea that if we could market that and then pool all of the health centers in New England who would essentially share in a central database all their physician vacancies, we could begin to advertise and market New England and the vacancies with an understanding, and it wasn't as easy as it sounds now, but with an understanding that Health Center A may not get that doc, Health Center B might get that doc, but because of the way we were doing it, the next doc might go to Health Center A because we differentiate then, well, would you prefer to be in Massachusetts? Do you like the water? It sounds really simple, but we were able to attract foundation money, Hearst money, federal money, and we improved recruitment of physicians for the first time in New England during that time became a issue number 3 or number 4 of importance, as opposed to it was always number 1. There were never
Greatest
enough.
need, sure.
And it also started a partnership, an understanding that there's strength in collaboration and partnership. So you fast forward it now to 1994, the community hospital in Lawrence General Hospital, and the health center, much smaller back then, had this wild idea. We don't have enough docs. We don't have enough docs. We don't know how we can get enough docs. Why don't we apply for a family medicine residency program? And why don't we make it community-based and have the health center run it? So the hospital will pass all the money through, all the CMS money through to you. You'll hire the faculty, you'll hire the preceptors, you'll recruit, you'll use our hospital as the teaching center. Your residents will become part of our house staff.
Yep.
Your docs will become chiefs of service. What a novel idea. Nobody ever did it. There were, I think, 8 residents in 1994, and there's 41, maybe 42 this incoming class now. 4 years, 4-year residency program, and out of the 200 graduates of this program since '94, 30% have remained at Greater Lawrence. An additional 30% still to this day go to and practice at other community health centers. 10% go back and practice in community settings. A percentage of, that's 30, yeah, there's 30 left. A percentage, about 10% over the time have gotten fellowships. 5% of those fellowships come back to practice with us. I mean, it seems like something out of a movie. So the impact, as we always said, if you give community-based residencies a chance, the folks that want to apply for them are going to be the right kind of physicians, and they're going to be the people that want to stay. The last piece of this that's amazing, Dan, is that out of the residents that leave us, out of all of those that leave us, 15% return. Right now, my chief medical officer is a graduate. My 3 clinical leaders are graduates. All 3 of my health center medical directors, I mean, all 6 are graduates. Even when I say it, I kind of get goosebumps. And you think back, as you said, 1980, why don't we all kind of work together and see if we recruit docs?
Yeah.
Now we're building a primary care provider base, and it's spreading. Now the question is, why isn't the country investing more in a model of care that's showing that we can get docs in the right places?
Yeah.
It's something, I've never seen it before, and it works, and we're really proud because it's only us. We keep asking the question, why are we the only FQHC that's doing it? I mean, we know why, because teaching medical schools and hospitals said they don't want that, but why is that model being supported and invested in nationally? And we know the Teaching Health Center program has started that.
Exactly. It hasn't achieved all of the hoped for goals that those who put it together had hoped, but it's done a fair amount.
It has.
It certainly has built partnerships.
Yes.
Between health centers and teaching hospitals.
Yes.
I just wish that more of them were like your hospital to say, here, take the reins and run it. You'll do a much better job. That's the final step that we have to take. So after all these years, I think I know the answer, but I got to ask you anyhow. What's your view of the future for health centers and for the communities that they serve? Even with Donald Trump there.
Yeah, that's what I was hesitating on. I think the future is unlimited for health centers because health centers have become more sophisticated, more diverse. They're leading the way in technology. They're leading the way in outcomes. They're leading the way in so many different parts of primary care, how to bring access to a community, how to leverage resources into building new services. And they're being recognized. It's being recognized throughout the country. I think as we have our retreat every year at NAC, the leadership retreat, there's more and more talk about how we can begin to collaborate and partner with larger organizations, with, God forbid, insurers, major health systems, community businesses, large businesses, because the bottom line is that health centers provide the answer. They provide the solution to how do you improve the quality of healthcare and the access to healthcare in a community. If you can do that, then people are going to want to work there, they're going to want to move there, they're going to want to locate there. So, I think the sky, present administration excluded, we both agree, but I think the sky's the limit. The folks that are now taking the reins, they're much smarter than I am, much smarter than I was, much more tuned to technology and to opportunity and to entrepreneurship. I really think I think we can become the base health system in this country if we are not already.
Yeah. I've got to express my admiration for you, my friend, because one of the things I've said often now over the last several years is I don't think I could go out and run a health center. Even after 8 years running the health center in South Texas, so much has changed in the healthcare system that if I did go back out, I'd need a crash course
Right.
in health center management, healthcare management today. You've managed to bridge that period, and you are one of the stellar health center leaders of today and tomorrow.
Well, we've bridged, thank you, Dan. We bridged that because we had to. You guys within the National Association have done the same thing from when you all got together, we all got together, to what the National Association does now and is involved in and is leading the way. I tell people if I couldn't apply and get hired at a health center right now, but
At your earlier,
right, at
yeah, when you
my
were
earlier
22, 23
time,
years
right.
old out of school.
I wouldn't even get a resume looked at. But I think because the folks that started this all had that community passion, and we were all smart enough to know that we got to change and move the model and improve the model, that what we're leaving is an incredible legacy. But the reason why I've been able to keep track is because I'm too scared not to. Things change so quickly that you just don't want to be left behind.
Yeah.
You want to be kind of ahead of the curve. It's been the best thing that's ever happened to me is this movement.
I think that's true for both of us, John. Thank you for the life you've given
Thank you, Dan.
to community health centers. And thank you for your support of NAC and your state and regional associations, because that's what keeps us strong as well.
Yes, it is. Without
Okay.
them, we don't have a backbone.
All right.